All right, get ready for a deep dive. We're taking a closer look at Polymyxin B and Colistin today. And to make sure we're on the right track, we've got the World Health Organization's Aware book by our side.
Great source.
It is, especially with all the concern about antimicrobial resistance. This deep dive is really for all you medical microbiologists out there.
Absolutely.
Those working on the front lines battling these, superbugs.
Right.
We'll be focusing on the access, watch, and reserve recommendations.
Okay.
Specifically for these last resort antibiotics. And trust me, things can get pretty complex, so buckle up.
For sure.
We'll be tackling everything from those tricky dosage calculations to, well, the mystery of Colistin's metabolism.
No, yeah.
And by the way, we might even reveal why Polymyxin B could be your new go-to, except, of course, when it comes to UTIs. So let's start with the basics. What exactly are Polymyxin B and Colistin?
So these are polypeptide antibiotics, and they're making a big comeback as our weapons against, well, as you said, those multidrug-resistant gram-negative bacteria.
Now, you mentioned a comeback. What's that all about?
Well, they were discovered a while back.
Okay.
Mid-20th century, actually.
Right.
But kind of got put on the back burner because of worries about their toxicity.
Oh, so the potential for, like, kidney damage?
Exactly. Nephrotoxicity was a big concern back then.
Interesting. So why are they back in the spotlight now?
Well, we're facing this huge problem, a rise in multi-drug-resistant bacteria.
Yeah, we hear about that all the time.
And especially the ones resistant to carbapenems, those are really tough to deal with.
Got it.
So Polymyxin B and Colistin have become essential, I'd say, for treating infections that are frankly becoming very hard to manage.
All right, that makes sense. So how do these antibiotics actually work their magic?
Well, they disrupt the bacterial cell membrane, leading to lysis, basically cell death.
So they're like popping those bacterial bubbles.
Kind of, yeah. They target lipopolysaccharides, which are a key part of that outer membrane in gram-negative bacteria.
I see.
And this disruption, well, it just throws the whole cell off balance.
Oh, so it can't keep itself together anymore.
Exactly.
It's fascinating, though. They're considered a last resort.
Yeah.
But there's still some mystery around how they actually work. Even the Aware book mentions this.
That's true. It's a bit of a puzzle. We know they mess with the cell membrane.
Right.
But the specifics, well, those are still being investigated.
Huh. Plenty of room for more research, then.
Oh, definitely. Lots to uncover about these potent molecules.
Okay, let's shift gears for a moment and talk about what clinicians actually see when it comes to infections caused by these polymyxin-resistant bacteria. What should they be looking out for?
Well, it can be tough.
Okay.
Because the symptoms can vary quite a bit.
I see.
Depending on where the infection is and, of course, the patient's overall health.
Makes sense.
But some of the common signs, well, you'll often see fever, chills, maybe a rapid heart rate, and sometimes even low blood pressure.
So pretty typical signs of infection then, right?
Pretty much.
Is there anything specific to those resistant to polymyxins?
Not really, no. It's more that these infections tend to pop up in people who are already really sick.
Oh, so people who are critically ill or have a weak immune system.
Exactly. That's where it gets tricky because it's hard to tell the infection symptoms from whatever else they're dealing with.
That makes diagnosis even more of a challenge.
Absolutely.
So how do we confirm if a patient actually has one of these infections?
Well, there are a couple of things we do.
Okay.
We definitely look at the clinical presentation.
Right, the symptoms we talked about.
But then we rely a lot on laboratory tests.
So what kind of tests are we talking about?
It's a mix. We've got microbiology tests. And then a bunch of other lab tests that help paint the full picture.
All right, let's break that down. First up, microbiology tests. What are they all about?
Well, the main goal is to pinpoint the exact bacteria causing the ruckus.
So we know who the enemy is.
Yeah, because that guides our treatment. We need to choose the right weapon, so to speak.
Makes sense. And what kind of samples would you take for these tests?
Depends where the infection's hanging out.
Okay.
It could be blood, urine, sputum, wound swabs, even cerebrospinal fluid if we're thinking meningitis.
So once you've got the sample, what happens next?
Off to the microbiology lab it goes.
Okay.
They'll grow it on special media. And once we have some colonies to look at, we can ID the species.
Right.
And the really important part, we can then do susceptibility testing.
So that tells you which antibiotics will work, including polymyxins.
Exactly. It's crucial for making those treatment decisions.
We got to make sure we're using something the bacteria is actually vulnerable to, right?
Precisely. Susceptibility testing helps us maximize our chances of success.
Now, you mentioned other lab tests, too. What do those add to the mix?
They give us more info on the severity of the infection
Wow.
and help us catch any potential complications early on. So things like a complete blood count or CBC can show signs of inflammation.
And then, what, blood chemistry panels to check how the organs are doing?
Exactly. We're looking at the patient's overall health, how their body's coping with the infection.
And sometimes imaging, like X-rays or CT scans.
Oh, for sure. If we need a better visual.
Right, like to see an abscess or if it's pneumonia.
Yep, those imaging studies can be super helpful.
So we've got clinical presentation, microbiology tests, other lab tests, even imaging. Now we know who we're dealing with, so what do we do about it? How do we treat these infections?
Well, like we've been saying, polymyxins are often our last line of defense, especially when other options have failed.
But we have to remember, they have those risks, right? The nephrotoxicity we talked about.
Absolutely. Can't forget about that. That's why the WHO in the AWARE book classifies them as reserve antibiotics, meaning they're only used when we've pretty much run out of other choices.
It's about finding that balance between effectiveness and safety, right?
Exactly. And every case is different, so there's no one-size-fits-all solution.
We got to tailor the approach for each patient.
That's the key.
Taking into account how sick they are, their overall health, even local resistance patterns.
All of that plays a role.
Okay, so let's zoom in on the antibiotic treatment with polymyxins themselves. We know dosage is key, but what about duration? How long do people typically need to be on these drugs?
Well, generally, the shorter the better.
Makes sense, given those side effects.
Exactly. We want to minimize the risk of kidney damage, so the AWARE book recommends keeping it between 7 and 14 days and possible.
So hit it hard and fast.
That's the idea.
Now, you mentioned combination therapy earlier. Is that common with polymyxins?
Oh, yeah. Especially for those really severe infections.
What's the thinking behind that?
Well, think of it like attacking on multiple fronts.
Okay.
We're hitting those bacteria from different angles.
I see.
This increases our chances of actually wiping them out.
Right, and hopefully prevents resistance from developing.
That's the goal.
So what kind of combinations are we talking about?
It really depends on the bacteria and what they're susceptible to.
Makes sense.
But often, we'll use high doses of carbapenems alongside the polymyxins, assuming the bacteria still show some sensitivity to them.
Oh, so we're not just throwing everything we have at the problem.
No.
It's about being strategic.
Absolutely. That's why susceptibility testing is so important, like we talked about earlier.
We got to make sure those antibiotics are actually going to be effective.
Precisely. It all comes back to that personalized approach.
Right. Choosing the right weapon for the right battle.
Exactly.
Okay, let's step back and take a look at what's happening at the cellular level. How are these polymyxin-resistant bacteria causing so much trouble?
Well, over time, they've developed ways to dodge our attacks, essentially becoming more resilient to the antibiotics we throw at them.
So they're evolving, basically.
That's right. It's a constant game of cat and mouse.
Interesting.
They can alter their cell membranes, making it harder for the antibiotic to bind or even change how they transport the drug into the cell.
They're finding ways to outsmart us.
Yep, it's an ongoing evolutionary battle, that's for sure.
And the more we use these antibiotics, the more they adapt.
That's the unfortunate truth. The selective pressure forces them to become resistant.
Okay, so let's zoom out a little further. What's the global picture when it comes to these infections? Where are they popping up the most?
Well, it's a global concern.
I see.
And they're increasingly showing up in hospitals and healthcare settings.
So this isn't just a problem in, say, developing countries?
Not at all. It's everywhere, even in the most developed nations.
Are there specific groups of people who are more vulnerable?
As we talked about earlier, it's those who are already critically ill. People with weakened immune systems, those undergoing chemotherapy, the elderly. They're the ones at highest risk.
And those are the ones we have to be extra careful with when considering polymyxins.
Absolutely. We need to weigh those risks very carefully.
Okay, let's dive into dosing now. We know it can be a bit tricky with these antibiotics.
It can, yes. Polymyxin B and Colistin, they come in different formulations.
Right.
And dosages can be expressed in various units. It can get confusing.
So let's break it down. Starting with polymyxin B, what are the typical dosages for adults?
Okay, so assuming their kidneys are functioning normally, we're looking at 1.5 to 2.5 milligrams per kilogram per day, divided every 8 or 12 hours.
Right, and how about colistin?
This one's a bit more complex, because it's often given as colistamathout sodium, or CMS.
Right, that's the prodrug.
Exactly.
Yeah.
And that gets converted to colistin in the body.
So for adults, what's the recommended dose?
9 million IU per day, of CMS divided every 8 hours.
It's a lot to keep track of with those different units and formulations.
It is. Accuracy is key here.
And we always have to adjust for patients with kidney problems.
Absolutely. Kidney function is crucial for getting rid of these antibiotics.
So if the kidneys aren't working well,
we have to adjust the dose to avoid toxicity.
That makes regular monitoring so important.
It is. We need to make sure the dosage stays within a safe range.
Okay, so we know how to dose them.
Yeah.
But who are these antibiotics actually targeting? What are the most likely pathogens?
So they're mainly effective against those gram-negative bacteria.
Okay.
Especially the ones that have outsmarted other antibiotics, like carbapenems.
So those carbapenem-resistant Enterobacterales, the Acinetobacter, the Pseudomonas we talked about earlier?
Yep, those are our usual suspects.
They seem to be the main culprits in these really stubborn infections.
They are. And they're especially common in hospitals.
Right, where people are already vulnerable.
Exactly. And to figure out which specific pathogens are susceptible to the polymyxins, we can turn to that AWARE book.
Oh, right, the table that lists the expected activity.
That's the one. It's called Expected Activity of Polymyxins Against Third-Generation Cephalosporin and Carbapenem-Resistant Bacteria based on the type of beta-lactamase produced.
That's a mouthful.
It is, but it helps guide our antibiotic choices.
So it tells us which bacteria are more likely to be knocked down by the polymyxins based on the enzymes they produce.
Exactly.
But we always need to confirm with susceptibility testing, right?
Yeah.
Because things are constantly changing.
Always. That's the gold standard.
Okay, before we wrap up this part of our deep dive, let's have a little fun, shall we?
Ooh, a quiz.
You got it. Ready to test your knowledge?
Bring it on.
All right, question number 1. True or false? Polymyxin B and Colistin are equally nephrotoxic.
That's a good one. But I'd say false.
And why is that?
Because colistin has a greater potential for causing kidney damage.
You are absolutely correct. That's a key difference to remember.
Definitely something we have to consider when choosing between them.
All right, on to question number 2. Which of the following units can be used to express colistin dosage? Is it A, IU of colistimethate sodium, B, milligrams of colistimethate sodium, C, milligrams of colistin base activity, or D, all of the above?
This takes me back to our unit conversion discussion. I think it's D, all of the above.
You're on a roll. Yes, understanding those units is super important for getting those dosages right.
Absolutely.
Okay, question number 3. Why is a loading dose so important when we're starting someone on polymyxins?
Because we want to achieve those effective plasma concentrations as quickly as possible.
Exactly. Hit those bacteria hard and fast from the get-go.
Right.
Question number 4. In what clinical scenario is colistin generally preferred over polymyxin B? Think about those unique properties we talked about.
Let me see. It's for urinary tract infections, isn't it?
And why is that?
Because colistin reaches higher concentrations in the urine.
Bingo. You're on fire today.
Thanks.
It's all about choosing the right tool for the job.
Right. Exactly.
Okay, final question. This is a tough one. What is a key challenge in identifying resistance to polymyxins?
This is a big one. I'd say the biggest challenge is those technical difficulties with the standard susceptibility testing methods.
You nailed it. Those methods aren't always reliable when it comes to polymyxins, which can lead to inaccurate results.
Exactly, and that can have serious consequences for patient care.
All right, that wraps up our quiz. You aced it.
Thanks. That was a good refresher.
It was, and it highlights just how complex this topic is. Now let's switch gears again and talk about a specific scenario. Imagine a patient coming in with a severe lung infection, but it's caused by a particularly nasty strain of Pseudomonas aeruginosa.
Okay.
And this bug, it's resistant to multiple antibiotics.
Oh, so even carbapenems.
Even carbapenems.
Yeah.
We're running out of options here.
So colistin might be our only hope.
It could be, despite those risks.
Right. And in that case, we'd be looking at intravenous administration.
Exactly. Colistin is usually given intravenously for systemic infections.
And that's usually done with colistimethate sodium or CMS.
Right. The prodrug that converts to colistin once it's in the body.
That's it.
Now, I remember from the AWARE book that there's also an oral formulation of colistin sulfate. But that's not for systemic infections.
Correct. That one's mainly for bowel decontamination.
Oh, okay.
In specific situations. It's not part of the WHO's essential medicines list for systemic use.
Okay, that clears up that confusion.
Yeah.
So back to our pneumonia patient.
Right.
What would the typical colistin dosage be, and for how long?
So assuming normal kidney function, the recommended dose is 9 million IU per day of CMS,
right,
divided every 8 hours.
And treatment would last.
Well, as we said, the goal is to keep it as short as possible.
Right, to minimize that risk of toxicity.
Exactly. Ideally, somewhere between 7 and 14 days.
And of course, we'd be monitoring those kidneys like a hawk, right?
Absolutely. Regular checks are essential.
But what if this patient doesn't respond to colistin alone? What are our other options?
Well, if the infection's really severe or it just won't budge, we might consider combination therapy.
So adding another antibiotic to the mix.
Exactly, hitting those bacteria from multiple angles.
But the choice of that second antibiotic, that depends on the specific bacteria and its susceptibility pattern.
That's right. And for Pseudomonas aeruginosa, we often look at adding carbapenem if there's still some susceptibility.
Okay.
Or maybe another type, like a fluoroquinolone or an aminoglycoside.
So the idea is to create the synergistic effect.
Exactly, boosting the overall effectiveness of the treatment.
But we're increasing the risk of side effects too.
That's the trade-off. It's always about weighing those benefits against the potential risks.
Right, it's not a decision to be taken lightly.
Definitely not.
Okay, let's shift gears a bit and talk about the global picture of polymyxin resistance.
Okay.
How do we keep tabs on how this resistance is spreading?
Well, that's where global surveillance comes in.
Right, we need to understand how it's evolving too.
Absolutely. Surveillance helps us track those new resistance mechanisms.
And identify hotspots, right? Areas where resistance is more prevalent.
Exactly. This information is crucial for shaping public health policies.
And guiding treatment guidelines.
For sure. It helps us stay ahead of the curve.
It's like having a global early warning system for antibiotic resistance.
That's a great way to put it.
Now, before we move on, I want to circle back to something we mentioned earlier, the whole issue of identifying resistance to polymyxins.
Right.
Those standard susceptibility testing methods aren't always reliable.
It's a real problem. Traditional methods like disc diffusion can be misleading because polymyxins don't spread well in agar.
Oh, so we could end up with a false sense of security.
Exactly. It might look like the bacteria are susceptible when they're not.
And that could have disastrous consequences.
Absolutely.
You mentioned broth microdilution is more accurate, but not always practical.
That's right. It takes more time and resources.
So is there any hope on the horizon? Are there any new technologies in the works?
Fortunately, yes. There's a lot of exciting research happening.
Tell me more.
Well, scientists are developing new automated systems and molecular techniques that can provide faster and more reliable testing.
That's good news. We need those advancements.
We do.
Yeah.
It could revolutionize how we detect resistance and guide treatment.
Okay, let's dive into the specifics of those challenges in identifying resistance.
Okay.
What are we up against here?
Well, one of the biggest hurdles is that resistance to polymyxins can develop through different pathways.
Okay.
Some bacteria acquire it through chromosomal mutations.
So they're literally changing their DNA.
Exactly. But there's another mechanism that's even more worrisome, plasmid-mediated resistance.
Plasmid-mediated, what does that mean?
So plasmids are these little pieces of DNA that bacteria can easily share amongst themselves.
I see.
And some of these plasmids, they carry genes that give bacteria the ability to resist polymyxins.
So they're like trading resistance secrets.
Pretty much. And that means these resistance genes can spread like wildfire through a bacterial population.
Not good.
Not good at all. And these mobile colistin resistance genes, or MMCR genes?
MMCR genes.
Yeah, they're becoming increasingly common, which is a major threat.
The WHO is pretty concerned about these, right?
Very concerned. It's a big focus in the AWARE book.
So we've got this perfect storm brewing. Unreliable testing methods, sneaky resistance mechanisms, and the potential for rapid spread of those resistance genes.
It's a recipe for disaster, really.
It sounds like we need a multi-pronged approach to tackle this.
We do. Antimicrobial stewardship is key.
So using antibiotics wisely.
Exactly. Only when they're truly needed.
And not just in hospitals, right? We need to promote this in the community as well.
Absolutely. And infection prevention and control measures are crucial too.
So the basics, like hand hygiene and isolating infected patients.
Those can make a huge difference.
And of course, we need more research, right?
Always. New antibiotics, alternative therapies.
I've heard about phage therapy, using viruses to fight bacteria.
That's one avenue. It sounds like science fiction, but it holds real promise.
Wow, it's amazing to see how science is tackling these challenges.
It is. It's a global effort. And organizations like the WHO are playing a vital role in coordinating all of this.
It's a reminder that we're all in this together.
We are. It takes collaboration and knowledge sharing to fight this battle.
Okay, before we wrap up this first part of our deep dive, any final words of wisdom for our listeners?
Well, the bottom line is that Polymyxin B and Colistin are powerful tools in our fight against these superbugs.
Okay.
But we have to use them carefully, always aware of those potential side effects.
Right, it's a delicate balance.
It is.
And as the WHO emphasizes, responsible use, careful surveillance, and ongoing research are essential for keeping these last resort antibiotics effective.
Couldn't have said it better myself.
Thanks for joining me on this first leg of our journey into the world of Polymyxin B and Colistin.
It's been a pleasure so far.
And we've only just scratched the surface. Stay tuned for part 2, where we'll delve even deeper into the complexities of these fascinating antibiotics.
Can't wait. So we were talking about this patient with a nasty Pseudomonas aeruginosa infection in their lungs.
Right, and we're in a tough spot because it's resistant to so many antibiotics.
Exactly. We're talking multidrug-resistant, even to carbapenems.
Leaving us with very limited options.
Yeah, it's tricky. Colistin might be the only effective therapy we have left.
Despite those risks, we have to weigh the benefits.
Absolutely. In this case, we'd probably be looking at giving Colistin intravenously.
Right. For those systemic infections, intravenous is usually the way to go.
And we'd be using colistimethate sodium, that's CMS.
Right, the prodrug.
Yeah, it gets converted to colistin in the body.
Now, the Aware book mentions colistin sulfate. That's the oral form. But that's not for these kinds of systemic infections, right?
Nope, that's primarily for bowel decontamination.
Okay, so different tool for a different job.
Exactly. The WHO doesn't even include it in their essential medicines list for systemic use.
All right, that clears that up. So back to our pneumonia patient, what would the typical dosage be and for how long?
Well, for an adult with good kidney function, the recommended dose is 9 million IUs per day of that CMS.
Okay.
Split into 3 doses every 8 hours.
And how long would treatment typically last?
We aim to keep it as short as possible to minimize that risk of toxicity.
Right, that's always the balance we're trying to strike.
Exactly. So ideally between 7 and 14 days.
And of course, we're monitoring those kidneys very closely.
Absolutely. Can't stress that enough.
But what if this patient just doesn't respond to colistin alone? What else can we do?
Well, if it's a really stubborn infection or if it's just super severe, we might have to think about combination therapy.
So adding another antibiotic into the mix.
Exactly. It's like attacking the bacteria from multiple sides.
Makes sense. But how do we choose that second antibiotic?
It all depends on the specific bacteria we're dealing with and what it's susceptible to.
Right, so those susceptibility tests are crucial.
Absolutely. For Pseudomonas aeruginosa, we often consider adding a carbapenem if there's still some sensitivity there.
Okay.
Or sometimes another type, like a fluoroquinolone or an aminoglycoside.
So we're trying to create this synergistic effect, boosting the effectiveness.
Exactly. But we always have to remember, combination therapy also comes with increased risks of side effects.
Right, another balancing act.
It always is, weighing those benefits against the potential harms.
Definitely not a decision to be taken lightly. Okay, let's zoom out again and think about the bigger picture, the global surveillance of polymyxin resistance.
Yeah, that's crucial. We need to know how it's spreading, how it's evolving.
And where those hotspots are, right?
Exactly. Global surveillance helps us track those emerging resistance mechanisms.
And then we can use that information to shape public health policies.
Exactly. We need to stay ahead of the curve, and surveillance helps us do that.
It's like having a global early warning system.
That's a great analogy.
Now, before we move on, I want to circle back to something we touched on earlier. The challenges of actually identifying resistance to polymyxins.
Right, that's a big one.
Those standard susceptibility tests, they're not always reliable.
That's the problem. Traditional methods, like that disc diffusion, they can be misleading because polymyxins don't diffuse well in that agar.
So it might look like the bacteria is susceptible, but they're not.
Exactly. We could get a false sense of security, and that's dangerous.
Really dangerous. You mentioned broth microdilution is more accurate, but not always practical.
That's true. It takes more time, more resources.
So is there any hope on the horizon? Are there new technologies being developed?
There is, actually. There's a lot of exciting research happening right now.
Oh, tell me more.
Well, scientists are working on new automated systems and molecular techniques that could give us much faster, more reliable testing.
That's encouraging. We really need those advancements.
We do. It could revolutionize how we detect resistance and make those treatment decisions.
Let's dig into the specifics of those challenges with identifying resistance.
All right.
What are the main hurdles we're facing?
Well, one of the biggest challenges is that polymyxin resistance can develop in different ways.
Okay, so different pathways to the same outcome.
Right. Sometimes bacteria acquire resistance through those chromosomal mutations.
So they're changing their DNA.
Exactly. But there's another mechanism that's even more concerning: plasmid-mediated resistance.
Plasmid-mediated, what does that mean?
So plasmids are these little pieces of DNA that bacteria can easily share with each other.
I see.
And some of these plasmids carry genes that make bacteria resistant to polymyxins.
So they're like swapping resistance secrets.
Pretty much. And that means these resistance genes can spread really quickly through a bacterial population.
That doesn't sound good.
It's not. And these mobile colistin resistance genes, we call them MCR genes.
MCR genes.
Yeah, they're becoming more and more common, and that's a big problem.
The WHO is pretty concerned about this, right?
They are. It's a major focus in the Aware book. It's a real threat to our ability to fight these infections.
So we've got this perfect storm brewing, unreliable testing, these tricky resistant mechanisms, and the potential for rapid spread.
It's definitely a cause for concern. We need to be proactive.
Absolutely. So where do we go from here? What can we do to tackle this?
Well, it's going to take a multi-pronged approach. First and foremost, antimicrobial stewardship.
So using antibiotics wisely and sparingly.
Exactly. Only when they're truly necessary.
And that's not just for hospitals. We need to get this message out to the community.
Absolutely. Everyone has a role to play.
Okay, what else?
Infection prevention and control measures are crucial.
So those basic things, hand hygiene, isolating infected patients.
Those can have a huge impact on preventing the spread.
They often get overlooked, but they're so important.
They are. And of course, we need ongoing research and development.
Right. New antibiotics, new therapies.
Exactly. There's a lot of promising research happening with things like phage therapy.
Phage therapy, that's the one using viruses to fight bacteria, right?
That's right. It sounds futuristic, but it's a real possibility.
It's fascinating to see all these different approaches.
It is. And it really highlights how collaborative this fight is. It's a global effort.
And the WHO is playing a big part in that, coordinating research and sharing knowledge.
They are. It's really important work.
Okay, we've covered a lot of ground in this deep dive. Any final thoughts for our listeners before we wrap up?
Well, I think the key takeaway is that Polymyxin B and Colistin are powerful weapons in our arsenal against these multidrug-resistant bacteria, but they come with risks.
Right, that potential for toxicity.
Exactly. So we have to use them judiciously, always aware of those potential side effects.
It's all about informed decision-making.
It is. And as the WHO emphasizes in that Aware book, responsible use, ongoing surveillance, and continued research are key to preserving the effectiveness of these last resort antibiotics.
Absolutely. We can't afford to lose these vital tools.
We can't. And that's why education and awareness are so important.
Well said. Thanks for joining me on this deep dive into the world of Polymyxin B and Colistin.
It's been a pleasure. A fascinating, albeit complex topic.
It is, and I hope our listeners have gained some valuable insights from our discussion. Until next time, stay curious and stay informed.
So we were talking about the challenges of identifying resistance to polymyxins.
Right, those tricky testing methods and how resistance can develop.
Exactly. It's a complex issue. One of the main hurdles is that resistance to polymyxins can emerge through a couple of different pathways.
Okay, so different routes to the same outcome.
Right. Some bacteria develop resistance through changes in their DNA. We call those chromosomal mutations.
So they're essentially evolving to withstand the antibiotic.
Exactly, adapting to survive. But there's another mechanism that's even more concerning: plasmid-mediated resistance.
Plasmid-mediated. I'm not familiar with that one. What does it involve?
Well, plasmids are like these little packages of DNA that bacteria can easily share with each other.
Okay, so they're swapping genetic material.
Exactly. And some of these plasmids carry genes that give bacteria the ability to resist polymyxins.
So they're passing on the resistance secrets.
You got it. It's like they're sharing a cheat sheet to outsmart the antibiotics.
And that means those resistance genes can spread like wildfire.
Yeah.
Right.
That's the worry. These mobile colistin resistance genes, or MCR genes as they're called, are becoming increasingly common, and that's a major threat.
The WHO sounds pretty alarmed about these MCR genes in the Aware book.
They are, and for good reason. It's a significant challenge to our ability to effectively treat infections.
Okay, so we've got this perfect storm brewing. Unreliable testing methods, those sneaky resistance mechanisms, and the potential for rapid spread of these resistance genes. It doesn't paint a very optimistic picture.
It's definitely a cause for concern, no doubt about that. We need to be vigilant and proactive in our approach.
Absolutely. So where do we go from here? What can we do to tackle this growing problem?
Well, a multifaceted approach is essential. We need to attack this from different angles. Antimicrobial stewardship is crucial, using antibiotics responsibly and only when they're absolutely necessary.
So promoting judicious use, making sure we're not overprescribing.
Exactly. And that goes for both hospitals and community settings. Everyone needs to be on board.
Right, it's a collective responsibility. What else can we do?
Infection prevention and control measures are equally important.
So the basics, like hand hygiene and isolating infected patients.
Those simple measures can have a huge impact on preventing the spread of resistant bacteria.
They're often overlooked, but they're so fundamental.
Absolutely. And of course, we can't forget about ongoing research and development. We need new antibiotics, new therapies to stay ahead of these evolving bacteria.
I've heard about phage therapy, using viruses to target and destroy bacteria. That sounds promising.
It does, doesn't it? It's like something out of science fiction, but it's a real and growing field of research. There's also a lot of work being done to better understand those mechanisms of resistance, which is crucial for developing effective countermeasures.
It's encouraging to know that so many brilliant minds are working on this problem.
It is. It's a global effort, and collaborations are key. Organizations like the WHO play a vital role in bringing researchers together and facilitating knowledge sharing.
We've covered a lot of ground in this deep dive, exploring the complexities of Polymyxin B and Colistin. Any final takeaways for our listeners before we wrap up?
I think the main message is that Polymyxin B and Colistin are powerful tools in our arsenal against these multi-drug-resistant bacteria, but they're not without their challenges. We need to use them judiciously, always mindful of their potential for toxicity.
Right, that delicate balance between effectiveness and safety.
Exactly. And as the WHO emphasizes, responsible use, ongoing surveillance, and continued research are absolutely essential for preserving the effectiveness of these last resort antibiotics.
It's a reminder that we can't afford to be complacent. We need to be proactive and collaborative in our approach to tackling this global threat. Thanks for joining me on this deep dive into the fascinating and sometimes daunting world of Polymyxin B and Colistin.
It's been a pleasure exploring this important topic with you. Thanks for having me.
And to all our listeners, thanks for tuning in. Stay curious, stay informed, and until next time, keep those microbes in check.